lecture series Uveitis part 10, and in this part we are going to discuss about the other parasitic diseases that causes uveitis. Number one is the toxocariasis. Introduction. The toxocariasis is caused by the infestation with the common intestinal ascarids, round worms of dog, Toxocara canis. So basically it is usually caused by the round worms of dogs, which is known as Toxocara canis. Puppies are more commonly infected than adult dogs and are almost also more likely to spread the organism. The feline variant Toxocara cati may also be causative. Human infestation is by the ingestion of the soil or food contaminated with ova shed in the canine feces. So when these species canine feces shed ova, these are basically ingested by human by contaminated soil or food. Young children are at particular risk from the soils of parks and playground. Once ingested ova develops into larvae which penetrates the intestinal wall and travels to the various organs such as liver, lungs, skin, brain, and eyes with resultant inflammation. So let's see figure 12.40. It is showing the Toxocara canis larva surrounded by the inflammatory tissue reaction. So clinical features: asymptomatic infestations is common. Uh, Visceral toxocariasis is also known as visceral larva migraine is a systemic infection of variable severity that usually occur in a child aged 2 to 7 years. So basically it is occurring in a child aged 2 to 7 and there is a variable systemic infection. Fever, abdominal pain, pneumonitis, lymphadenopathy, hepatomegaly, myocarditis are some of the possible features. So all these can occur in a case of a visceral toxocariasis. There can be heart involvement like myocarditis, there can be the lymphadenopathy, there going to be the liver involvement causing hepatomegaly, causing a pneumonitis, abdominal pain. Spontaneous recovery is usual. Death is very rare and usually occur in individual hypersensitive to parasitic antigens. Covert toxocariasis is associated with mild systemic symptoms. Ocular toxocariasis, ocular larva migraines generally occur independently of visceral larva migraines and is associated with low parasitic load. It is typically unilateral in around two-thirds causes some degree of permanent visual impairment. In contrast to the visceral toxocariasis, it tends to occur in older children and adults. Chronic endophthalmitis typically present with leukocoria, strabismus, floaters, or unilateral visual loss. So there can be the chronic endophthalmitis that can occur, which is basically with the leukocoria, means the whitish reflex of the eye. There can be the strabismus, deviation of the eye. There can be the floaters or unilateral visual loss. Features may include interior uveitis, vitritis, chorioretinitis, papillitis, and a fundus granuloma. So pan uveitis can occur, and they're going to be the inflammation of the optic nerve as well, which is known as papillitis. There can be the fundus granuloma. A dense grayish white exudate similar to snow banking seen in pars planaris may involve the peripheral retina and pars plana. Complications leading to a poor visual outcome include fractional retinal or ciliary body detachment with hypotony leading to phthisis bulbi. Posterior pole or peripheral granuloma without inflammation classically occur in an older child or adult with unilateral impaired vision or as an incidental finding. So there can be the granuloma that can occur in the posterior pole or it can occur in the periphery, and it usually occur in an older child or adult. A 1 to 2 disc diameter sized round yellow white granuloma is present in the posterior fundus or periphery. Vitreoretinal traction may lead to complications due to macular distortion and or retinal detachment. There can be the chorioretinal scar, diffuse unilateral subacute neuroretinitis, see below. So these can all be the findings in the case of a uh, ocular toxocariasis. So let's see figure for 12.41 is showing chronic toxocara endophthalmitis. A is showing leukocoria. B is showing pathological specimen showing an inflammatory mass and a total retinal detachment. So this is showing a toxocara granuloma. A is showing a granuloma with a vitreous band. So this is a granuloma and there is a vitreous band. with it. B is showing peripheral granuloma with a vitreous band extending up to the disc. So this is a granuloma peripheral and it is extending up to disc. C is showing mid-peripheral granuloma with underlying chorioretinal scarring. So what are the investigation? It is particularly important to distinguish a toxocara granuloma from retinoblastoma. Other helminthic organism can give similar clinical manifestations. Full bud cloud eosinophilia may be present, particularly in visceral larva migraines, and can become chronic. Hypergamma globulinemia, especially IgE. So all this can be increased. Basically, in the case of parasites, eosinophils are increased. So eosinophilia may be present in CBC, and IgE can also be increased. Serology: antibodies to Toxocara canis are detectable in only about 50% of ocular cases. Positivity is common in general population, 14% overall in US. Ultrasonography may be useful if the vitreous is hazy. Aqueous or vitreous sampling for eosinophilia, antibody detection, and PCR. Biopsy of the granuloma of the skin or elsewhere for larvae is sometimes possible. So, what are the treatment? Prevention is by the good hygiene practice and deworming of pets. Steroids is topical. You can give topical, regional, and systemic may be considered for the inflammation. Anti-helminthic agents such as mebendazole and thiabendazole can be considered in ocular toxocariasis. Remembering that warm death may promote inflammation. Vitrectomy for the sight-threatening tractional sequelae. So next is the onchocerciasis. Introduction: onchocerciasis, which affects the eye and the skin, is the second most common cause of the infectious blindness in the world. So it is the second most common of the infectious blindness. It is endemic in the areas of Africa and other regions, and disease is particularly severe in savanna regions, where in some areas more than 50% of the older adults are blind from the condition. Chronic onchocerciasis shortens lifespan by reducing resistance to other disease. The parasitic helminth Onchocerca volvulus is a causative. So basically, in a case of onchocerciasis, the causative organism is a parasite known as Onchocerca volvulus. The vector is the Simolinium blackfly, which breeds in the fast-flowing water, hence the colonial term river blindness. And basically, there is a vector which transmit the larva into the human, and that is a Simolinium fly, and it is found in the rivers. So these are known as a river blindness. Larvae are transmitted when the fly bites to obtain the blood. They migrate to the subcutaneous site to form the onchocercomas, where microfilariae are produced by the adult worms. Uh, uh, Degenerating microfilariae excite an intense inflammatory reaction, accounting for most of the clinical manifestation of the disease. The rickety Wolbachia lives symbiotically in adult worms, and microfilaria is important for microfilaria production. So let's see figure 12.44. It is showing the life cycle of the Onchocerca volvulus. So you can see that there is a fly which bites to the human, and when it bites to the human, it transfers the larva into it, and basically there is a adult worm in the subcutaneous nodules which produces microfilariae, and which causes the formation of the granulomas known as onchocercomas. And basically microfilariae will degenerate. This is caused the inflammatory reactions. And sometimes a rickety name known as Wolbachia lives symbiotically, means with the adult worms, and it is very important for the microfilarial production. Diagnosis is by the skin snip biopsy, serology, tear or urine antigen detection, oncodipstick, and PCR of the lesional fluid. So you can diagnose it by the biopsy. You can use the oncodipstick test for the antigen detection of the onchocerciasis, and you can also do the PCR of the lesion fluid. So, what are the clinical features of it? Systemic features are principally dermatological and include pruritus, a maculopapular rash, oncodermatitis involving the buttocks and extremities, and the areas of hypo and hyperpigmentation on the skin. So, basically, they're going to be a dermatological symptoms, like you can also see pruritus, you can see the maculopapular rash, which is known as oncodermatitis, and which involves the buttocks and the extremities, and there can be the hypo and hyperpigmentation on the skin, which is known as leopard skin. So you can see figure 12.45a is showing as a maculopapular rash, and B is showing the hypopigmentation along the skin, which is known as leopard skin, and C is showing the subcutaneous nodule onchosarcoma. Scratching of the itchy areas lead to lichenification. Onchosarcomata are non-tender subcutaneous nodules that encloses 2 to 3 adult worms. Severe lymphadenopathy can occur and with secondary lymphedema. Eosinophilia is typical. So there are going to be the inflammation of the nodules as well, lymph nodes as well, and there can be the lymphedema as well. Live microfilariae may be seen in the cornea, vitreous, and suspended in the AC after the patient has postured face down for a few minutes, followed by immediate slit lamp examination. So what you can see is basically you ask the patient to do the face down for a few minutes, and after that, when you see in the slit lamp, you can see the interiorly the live microfilariae. Interior uveitis is an early feature. Pear-shaped pupillary dilatation may be seen and is due to posterior synecdoche. There can be the keratitis, punctate keratitis, snowflake opacities affects a third of the patient and consists of infiltrate surrounding dead microfilariae. Initial lesions are more commonly located at 3 and 9 o'clock in the interior third of the stroma. Slowly progressing sclerosing keratitis may eventually involve the entire cornea. So basically the lesions are usually located at the 3 and 9 o'clock position in the interior third of the cornea. So you can see figure 12.46a is showing advanced corneal scarring in this case. So there is a keratitis associated with onchocerciasis. Then there is a chorioretinitis, is usually bilateral and predominantly involves the temporal fundus sparing the macula until late. So macula spared until late. Widespread choroidal sclerosis and atrophy can ensue, and perpetuating autoimmune response is hypothesized for progressive longer-term chorioretinopathy that may persist after control of infection. Optic neuritis may be acute. So you can see figure 12b is showing intraretinal pigment clumping and RPE atrophy, and C is showing choroidal pigment clumping and chorioretinal atrophy. So what is the treatment of this? Ivermectin, supplied in many countries by Merck at no charge, kills microfilariae but not adult ones, and is given at least annually for many years. It has been effective in substantially reducing transmission rate and morbidity, and no recent new cases have been reported in many communities. Ivermectin occasionally precipitates inflammation, so prophylactic prednisolone may be considered in patients with visible AC microfilariae. Ivermectin may cause toxic encephalopathy and in patient with the Lua infection. So basically what you can give is ivermectin, which is basically kills the microfilariae, which is basically causing the inflammation. So this is usually for the case of acute so basically in a case of acute infection, it causes the when given, it causes more inflammation, so that is why it is given with the steroids to control the inflammation. And it also causes the toxic encephalopathy in a patient with the Lua infection. Moxidectin is a newer drug that may be superior to ivermectin. Doxycycline 100 mg to 200 mg per day for 6 weeks target Wolbachia, indirectly preventing microfilariae embryogenesis and substantially reducing the numbers of an extended period. So, Wolbachia is basically living symbiotically with the microfilariae and is important for the production of the microfilari. So when it is killed, it is also decreases the production of the microfilari. It also has some effects on the adult forms and may be useful adjunct to ivermectin or moxidectin. Suramine is effective against adult forms. It is given intravenously. Steroid anterior uveitis is responsive. Tip: ivermectin given annually is effective in reducing transmission rate and ocular morbidity in onchocerciasis. Next is the cysticercosis. Cysticercosis refers to the infection by the Cysticercus cellulosae. So basically, it is caused by the Cysticercus cellulosae, the larval form of the poke tapeworm, Tinea solium. So it is basically the tapeworm. Poke tapeworm is known as a Tinea solium, and its larval form is Cysticercus cellulosae. So that is causing the cysticercosis. Ingesting cyst of the Tinea solium in an undercooked pot leads to the intestinal tapeworm development tenacious. The invested human then shed eggs that leads to the larval infection. Cysticercosis when ingested by the same or another individual. So basically, what happens is when a patient is eating an undercooked pork which contains the Tinea solium, and when it in the intestine, it is given to adult tapeworms, and when these tapeworm, they shed eggs, and these eggs are then again eaten by the same individual. It causes the cysticercosis larva. So when these eggs are they form the larva, this is known as cysticercosis. Inflammation develops in response to the antigen released by the dead organism. Clinical features: systemic disease may involve the lung, muscle, and CNS. Neurocysticercosis. So basically, it mostly involves the CNS, which is known as neurocysticercosis. MRI and CT imaging are effective at demonstrating cyst, and plain X-ray may show calcified cysts. Serology and stool analysis are useful for diagnosis. So it usually shows the calcified cyst in the brain. Ocular features include cyst of the conjunctiva and occasionally the orbit and the eyelid. The AC may show free-floating cyst. Larvae can enter the subretinal space and may cause exudative retinal detachment. They also pass into vitreous, where released toxin can incite an intense vision-threatening inflammatory reaction. So it causes the cyst in the orbit, in the eyelids, in the AC, and it can also be larvae can also be found in the subretinal space, and which causes the exudative retinal detachment. So we can see figure 12.47. A is showing us ocular cysticercosis. A is showing anterior chamber cyst. B is showing subretinal cyst showing tract of the larvae. C is showing subretinal cyst with overlying exudative retinal detachment. Treatment: systemic steroids to control inflammation are combined with the surgical removal of larvae from the AC, vitreous, and subretinal space. So basically, what you give is steroids to control the inflammation, and we remove the larvae surgically from the AC, vitreous, and subretinal space. Antihelminthic agents such as albendazole may be appropriate in systemic disease, but should be used in caution under specialist guidance and often with the steroid co-administration. Next is the diffuse unilateral subacute neuroretinitis, which is known as Duchenne. Introduction: Duchenne is a clinical syndrome due to a presence of a single motile subretinal nematode, such as Toxocara Bellis, Bellisa, Bellis, Bellis, Bacillus ascaris, Procyon, and Ankylostoma caninum. Misdiagnosis: for example, multifocal choroiditis is common as the verb is often small and may be overlooked. So basically, subretinal nematode is causing this diffuse diffuse unilateral subacute neuroretinitis, most commonly caused by the Toxocara Bellis ascaris, Procyon, and Ankylostoma caninum. So what are the clinical features? Presentation is with the insidious monocular visual decrease. The disease is diagnosed clinically as special investigation are not helpful. ERG is subnormal even in early disease. So ERG is abnormal. And there is a monocular decrease in visual acuity. Acute disease, crops of gray white outer retinal lesion. There can be vitritis, inflammation of the vitreous. There can be papillitis and retinal vasculitis. End stage disease include optic atrophy, retinal vascular attenuation, and diffuse RPE degeneration. Treatment: photocoagulation, 200 micrometer, 0.5 to 0.5 second, and 150 to 300 microwatt is a treatment of choice when a worm can be visualized. So basically, when you see a worm, you put the laser in it, and the laser settings are that it is spot size is about 200 micrometer. You give it for 0.2 seconds, and the power is almost about the 150 to 300 megawatt. If necessary, a straight beam or a very slight light laser burns are first used to shepherd, sometimes lure the photosensitive nematode away from the fovea. Systemic albendazole 400 milligram for 30 days or vitrectomy may be appropriate. In some cases, steroid cover may be prudent with all treatment modalities. So basically, these are the nematodes that are present in the subretinal are causing such kind of neuroretinitis. There can be the vasculitis, there can be inflammation of the vitreous, papillitis as well. So let's say figure 12.48 A and B. So just showing the diffuse unilateral subacute neuroretinitis. A is showing active lesion and B is showing end stage disease. So that's it for the uveitis part 10. See you in the next lecture.